welcome to Connect the Dots Learning Center podcast. I'm Stephanie Wagers, your host, and I'm so glad you're here. Whether you're a seasoned therapist, clinic owner, or just starting out, this podcast is your go-to spot for insights, tips, and stories that'll help you connect the dots in your practice. If you've ever felt stretched thin or overlooked as a pediatric OT, this episode is for you. Today, I'm joined by Dr. Nicole Quint, educator, consultant, and advocate, who's here to talk about burnout, invisible disabilities, and how to reclaim your power as an expert. Let's dive in. Welcome, Nicole Quint. I'm glad to have you on here. We've been trying to make this happen for a while. You're very busy. You're an educator, a consultant, med bridge instructor, and a podcast host now. But where I want to start is kind of that term that you use, the quintessential OT. What does that mean to you?
Hi, yes, Stephanie, thank you so much for having me. So my background is I've been an OT for over 20 years, and I started out in working across pediatrics and adult brain injury, neuro, strokes, spinal cord. So I kind of ran the gamut of all ages, which was really nice. And when you're in the hospital setting, you have all these people working with you. So it was very team focused. When I moved to the university, I was kind of party of one. And I was in our private school, and then I was in the outpatient clinic. And so I took my background and my interest in vision, executive function, social participation, and really getting people, from this traumatic brain injury kind of situation back to their life with this kind of new situation. And a lot of them were kids, a lot of them were tweens, teenagers, adolescents. How do we do that? And then I started thinking about the kids that I was seeing in outpatient were more coming to me referred for invisible disabilities, or diagnoses. So ADHD, sensory processing disorder. And I'd always had an interest in that. And I had been treating outpatient at the hospital, but now it just took on like a new focus. And I was really working with the families. I was working with a lot of the kids that I was seeing also were at the private school on campus. So there became this whole opportunity to teach the teachers, train the trainers kind of a thing. And, that we had over there working with students here. And I just started to see this bigger picture of how do we really try to change practice when we tend to be kind of one-on-one, working with just a kid and his or her family in the clinical setting and kind of feeling like you are a party of one. Like I'm just kind of by myself when I was used to this whole big team with me before. And I started working with the optometrist here, audiology, expanding my my team approach here was a little different, but it was really quite nice. And I had the teachers and just started really thinking about how to include the parents a little bit more. And so started to think like, what is the exemplar, right? What are we looking for? What's an exemplar OT? I had all these amazing mentors as I was going through, at the hospital when I came here into academia in my doctoral program. And so it was like I was learning from all these amazing people who I felt were exemplars in different ways. And then, of course, my last name is Quint. So it was like, quintessential is kind of like, what's the exemplar? So when I think of OT, we have a challenge that nobody knows what we do, and the name is confusing, and we have these overlaps with some other similar professions, our partners out there. So it's kind of like, what's a quintessential OT? And to me, a quintessential OT is someone who uses evidence-based practice, who is true to occupation and uses occupation-based and centered approaches, who uses occupation in their language when they're talking to people. And we really lean into our identity, understanding our role very clearly and being able to communicate that, I think is very important. Partnering with families and the clients that we're working with, as well as the other professionals, including other OTs and OTAs that we work with, is very important. And to me, the quintessential OT is someone who's confident and competent in that role, and then is not afraid to say, I am an OT. I love what I do. I think what we do, I know what we do is really important. And we have to create that narrative. And
Mhm.
so that's to me the quintessential OT is really practicing that occupation based approach in a confident and competent way.
Yeah, I love that. Are you still teaching?
I am. So I am at Nova Southeastern University. I've been there 15 years. And luckily now I'm a program director for post professional programs. And
Mhm.
so I get to work with seasoned OTs who come back and want to get their doctorate. And we really focus on changing practice through practice scholarship. So still very steeped in practice. And I love that. I love working with students. I love working with people who are in the clinic doing amazing things.
Mhm. So, like you said, you've worked in so many different settings. Have you had a favorite?
Oh, I don't think that's
Or
one
one that you didn't prefer?
one that I didn't prefer. No, I mean, I loved all of it. I think I tend to be someone who sees opportunity. So when I was in the hospital, I would see all these opportunities and I was always kind of like, I'll do it. I was always the volunteer, even if I didn't know what I was doing. And when I came here, the one of the first things they told me was, "Oh, the middle school on campus would love to have OTs come and be a consultant and provide kind of this bigger approach to programming instead of just one-on-one and working with the kids and the teachers." And I was like, I don't know what that looks like, but maybe I'll figure it out. So I just signed up for it. I love them all. I don't know if I have a favorite or at least favorite. I do know I kind of always wanted to work in the NICU and I didn't get to.
Yeah.
The rest of it, I love working with teenagers and middle school kids. And I don't think a lot of people love that.
No.
Um, I love their awkwardness. I love I love when they're going through these transitions. That's probably my favorite. So it's not so much the setting as it is the population. And I love working with kids that have invisible disabilities. And it's a real challenge to make, it's different when you're working in an arena and someone can see the disability.
Mhm.
It's a visual cue that we rely on as human beings in society to say, oh, this person might need different support, right? But when you have an invisible disability that cannot be seen, there is no prompting or cueing to the people, the adults in that world to say, this person needs a different lens and needs some different support, needs some
Mhm.
ingenuity. Instead, it becomes, why is this kid being so difficult? Because it can be this I kind of call it a professional paradox. Here you are a professional and you want to do well in your role and you want to do right by these kids, but you're not really understanding what they need or why they need it. And it feels all the like they're not following your directions, they're not doing what they need to do, they're being difficult for
Mhm.
whatever reason. It becomes almost like a conflict. And so it's a challenge, but I love opening up you know, eyes to, what these kids need in their families because it can really turn into a real challenge. And that was what I did my dissertation on was
Nice.
conflict and special education for moms who have children with invisible disabilities because it is really
Mhm.
challenging. These
Yeah.
kids like they would need any extra support.
Wow. That's amazing. Do you feel like that this has gotten better across the years and throughout, the different areas of practice? And what could we do better as a profession to kind of bring awareness to this?
So that's a great question. So I do think it's gotten better. I definitely see lots of people doing great things out there and talking about things. I can remember back in the day when I was just learning about interoception, and it was like, okay,
Mhm.
no, there's really no guidance. Like, what do? I got to try to figure this out. I really know sensory well, and I've had wonderful, I did mentorships with the Star Institute and I did all these, advanced trainings. And it was like, okay, but what do we do for interoception? Now I see it out there, and there's some great leaders out there really, helping us with that. And I can remember doing, sometimes you bridge your hospital training, and it was like, okay, I got to teach this kid how to know when they need to go to the bathroom, how how to finish going to the bathroom, like
Yeah.
upon emptying your bladder, if they don't get that message. So like how there's no guidance. So it was like, okay, but I had spinal cord training. So it was like, okay, maybe I could use some of this and then add a sensory component to it. And so I was just kind of making things up as I would go. And I mean, maybe that's what's essential, right? I think a lot of OTs out there and OTAs are probably going, yeah, I do that all the time. Um, so I do think things have gotten better. I think we're starting to see, hey, we need more professional guidelines. We need more information on this. As more research comes out, how does that get integrated into practice? But then there's still the gaps, there's still a lot we don't know. But then there's also things that are disheartening that are kind of hard. When I did my dissertation and I would hear what the mothers would go through, and that there's misinformation out there. For example, one of the things that I had heard, one of the parents was that teachers were relating um, ADHD to mothers drinking when they were pregnant.
Mm.
So there's misinformation out there that sometimes you don't know what you don't know. So while I think we've gotten a lot better, I think one of the things we could be doing better is not assuming people know what we know. So one of the things that I think we suffer from as OTs is um, almost like a lack of confidence. We tend to be a little insecure. I think that's normal because people don't understand what we do. People get confused. People don't know where to put us. And so if you're not comfortable constantly advocating for yourself, that can be challenging. And even someone like who's kind of a challenge the process kind of person and always willing to kind of fight the good fight, it sometimes can be something that feels like, it could take a hit to your sense of feeling confident or feeling like you really are, you have that self-esteem in your role. So I understand that. So I think as a profession, we're smaller. People are
Mhm.
confused by our name. People are confused about what we do. They have a general awareness. So it's easy for us to have this collective, maybe lack of self-esteem. Um,
Yeah.
we lean into what we love. We have this strong identity. So it's this interesting conundrum, right? Our
Yeah.
paradox that it's like we have this like strong identity, but yet we're like, um, so I think what we could do better is understanding that while we are expansive, we know a lot about a lot of things. What we do is expansive. We do know a lot and we have expertise.
Mhm.
And can't just assume that what we know is general knowledge,
Yeah,
right? And that we do that sometimes. So I think when we're
we
working,
do.
right? So I think sometimes when we're working with parents or teachers or other professionals, physicians, for example, or nurses. We're like, well, they know what ADHD is. Everybody knows what ADHD is. It's on the news. There's medication. Everybody hears ADHD, ADD, whatever. It's out there. But when you really take a step back, do people know? I mean, we're hearing on the news now that they're still saying what causes autism, and there's still confusion about autism. So to me, it's like we can't assume anything. So I think that what we need to do is just engage in basic, like fundamental education for everyone we meet. And
Mm.
it's almost like let's write our own narrative, but let's also write a narrative that is supportive to the families that we're working with and the clients we're working with. So, okay, you know what Down syndrome is? Great. I'm going to give you a little bit of information because I want to make sure we're all coming from the same foundation. Now, Down syndrome
Mhm.
again, is another one. A lot of people know it, but do they? We
Mhm.
things, and we've had extra education, and it is really important for us to appreciate that we need to share that information in a way that is bringing people in, so that we're all kind of coming from the same place. And I think
Yeah,
that,
I love that. I love that. And we are experts in child development and occupational therapy. And this is one thing I see a lot with pediatric clinicians is this feeling that my knowledge is this basic knowledge and the parent should know that, but they don't. And we've got to bridge that gap for them of why am I using this tool or this intervention to help your child be able to tie their shoes or whatever it is the goal, because they can't do that. And until we can really explain the power of our interventions, I feel like our worth isn't going to take off.
And we have to think about the families we're treating as occupational beings too. These are
Yeah.
moms, dads. They have their role as a parent is an occupational role, and
Mhm.
we're helping them to be more successful in their occupational performance as a parent or their participation. Maybe they are like kind of standing back because they're like, I don't understand the sensory stuff. How do I get more engaged in that? Or how, the school system is daunting. The IEP process 504 is daunting. Now there's even more going on because there's changes. How do we guide them so that they feel more secure in their role and able to, effectively participate and perform in that role? They're just going to feel better. Then they can advocate better. So I do think we can't assume that that what we know is foundational or basic or anything. It's not. So I think
Mhm.
that's the thing, is everybody lean in and say, I am an expert. I am an expert in development. I am an expert in all these different diagnoses that are out there. I am an expert in occupation. I am an expert in occupational analysis and breaking down occupations. That is our superpower. We don't
Mhm.
really. So I always tell people, I even took it for granted. And I started teaching for an organization named PESI that does continuing ed,
Yeah.
all different providers, right? And they would send me all over the country. And I did this like 6 hour, 1 day executive function course. So everybody in the audience was, everything from teachers to OTs, OTAs. I had rec therapists, I had psychologists, I had physicians, I had PTs, speech therapists. It was everyone. And I would only have probably maybe 20% were OT. So it was not really OT focused. And at the end, I have them do goal attainment scaling. And what we would do before that is I have them work through a case. And I say, let's do the occupational analysis. And then I tell them we'll call it activity analysis so I can be inclusive. But with my OTs, I'm like, it's occupational analysis. Um, and they don't know how to do that. And I didn't realize it because, again, I was sitting there thinking this is basic knowledge. I wasn't appreciating how special it is that we can do that. What a skill set that is that we need to really appreciate that we can do. And yeah, people can break, a common one would be like, loading the dishwasher because we would talk about chores and things. And they kind of think about it, but we think about it at a level of, the analysis that we do has a depth
Mhm.
that other people are not trained in doing. They don't have that skill set and they're not going to. I couldn't even teach them in an hour how to do it the way we did. We went to school for this. And so I started to realize, and I thought, wow, again, we don't just have basic knowledge. We have this skill set that we underappreciate. Maybe that's the word, is that we underappreciate it.
Yeah.
Leaning into
Yeah.
that is important because that's where we derive our success, is
Mhm.
break down these occupations into doable steps, but we need to do that for our families too, right?
Yeah. Yeah. And the next this leads really nicely into burnout. And I think that this may be a component of especially pediatric providers burnout, that we're not doing a good job explaining what we're doing. And so we're not getting that engagement from the family or the parents. And so I know a lot of providers can feel like, oh, I'm having to do everything. I'm having to manage the behavior. The parent's not in the room or whatnot. We have a hard job and kids have big emotions and we've got the whole family component as well. Um, talk to me a little bit about burnout and how maybe some of your courses even can help with that.
Yeah, I think burnout, it's tricky. I mean, when you think about it, there's so much placed on our shoulders, and therapists are working hard. The productivity demands are intense.
Mhm.
You're wearing the family stress on your back. Um, I talk to therapists all the time, and they're just thinking about the kids and the families, and I think it's very different when you work in pediatrics or you work in even with adults or something, and you have someone for a long time. You get to know them. They become part of your world. It's not such a short-term thing. And I think that can even be more daunting and add to that burnout risk. But I think, what the evidence says, there's a couple things that really help with burnout that I think are probably underutilized. The first thing is having a mentor.
Mhm.
And we always think of a mentor as having an expert mentor that is more seasoned than we are, that knows more than we are, and then we learn from them. But what we under and that's important, and you should have a lot of them. It's hard when you work in the school system or you work in home health or something, you're kind of by yourself to find that, so that's where it's really important to find coaching or mentoring or take courses with people. Like maybe you have a certain individual you're really following, or maybe hopefully you have someone that you can work with directly. Um, but but probably more important than that is a peer mentor. And this is something we definitely underutilize. The research is very clear that if you find a peer, they do not have to do the same things as you. They just have to have some of the same challenges. And getting them to support you, you support them, you're solving problems for them, they're helping solve problems for you. It becomes this really supportive piece. I've always had peer mentors. I've had my expert mentors too, but my peer mentors never had the same situation as me. But we had very similar challenges in different roles, and so that peer mentor is vital. And I can't tell you how much that can really help you. It energizes you. You have someone supporting you. It makes you more resilient when you have that support. But then you're hearing how maybe they're tackling something like, "Ooh, I could take something from that. That's
Yeah.
perfect." Yeah, right. Success stories are motivators.
Right.
Helping someone else while you're getting help too. So it fills your cup while you're filling someone else's cup, and you're not just being depleted. We tend to feel
Mhm.
like we're depleted with our families, maybe that we're working
Mhm.
with. So I really recommend that. I think the other thing is reflective practice is super, super important. The research is very clear that you want to engage in reflective practice. There's the reflective practice in the moment that I think OTs are sensational at, where you're
Mhm.
changing what you're doing to meet a goal. We do that, you know, all the time. And it's hard. The thing I always think about with students are always like, I want to be able to do it in the moment. I'm like, that comes with practice. you know, the other part is practicing after the fact. The practicing, reflecting on is what they call it. So after the fact is saying, okay, what did I do? What could I do better? What worked? That kind of thing. And just having that be automatic is actually um, really good at helping you with burnout.
Mhm.
Think you tie that to the peer mentoring, and now all of a sudden, you kind of have this approach that can be really helpful for you as you're feeling like I'm moving forward and I'm not getting stuck in the quicksand that drains me. You-
Mhm.
Those are two things that are really helpful. The other thing I think, the third thing I would add to that is looking at your families as partners instead of recipients.
Mhm.
I think a lot of this is changing our mindset. So instead of feeling like we're maybe a victim of a name that's confusing or people not knowing what we do, or we're being slighted in some way, that kind of stuff doesn't feel good. Instead, it's like, you know what? When I see someone who doesn't know or tells me they don't know what OTs do, I see it as an opportunity for me to write that narrative. Now, all of a sudden, I have power and agency I can lean into and say, you don't know what that is? I'm going to shape your knowledge. You're going to know what it is and you're going to respect it and you're going to want more of it because that's really what happens once they find out is they have mad respect for what we do when they know what it is and how we think about things and why we're doing what we're doing, and then they want more of it. When I was in
Mhm.
this stuff, they could have put me everywhere. They were like, "Can you do this? Can you do this?" You
Yeah.
know, that to me, that feels so much better, and that's so much more empowering instead of,
Mhm.
you know, nobody knows what we do and this stinks and I hate that everyone thinks that I find people jobs, you know. Um, so I think when we lean into it, and by the way, by rejecting the fact that we do jobs, I think actually shortchanges us because that could be an area of opportunity where we really start to help people in the workplace, especially at
Mhm.
the. So I don't want us to like kind of, you know, cut ourselves short because of this like internal conflict with the whole occupation name and confusion and lack of awareness and knowledge. See it as an opportunity and embrace it and say, I'm writing this narrative.
Mhm.
That makes, I think those things, and partnering with the family and saying, you're my partner in this. We're going to do this together, I think changes everything.
Yeah. I think, you mentioned that there's so much that we do as OTs, right? Once they learn what we can do, it's like, oh, you can help with this, oh, this, and you just get pulled in so many different directions. I know personally, it's like, I've been in this practice for 25 years and there's still so much I don't know, right? And sometimes that is hard to kind of handle on a daily basis, which I think can lead to some burnout for people because it's like you want to get masterful in what you do and kind of go into autopilot, I guess, because work is hard sometimes, but we can't do that as OTs. We're constantly thinking. But taking that and then leading more into kind of your CEUs that you've done and MedBridge, what are some foundational courses that you feel like would be really, really good for doesn't have to be a new grad, but somebody newer to the pediatric field?
Mhm. So, so yes, so I think, continuing education is tough. The
Hmm.
is not necessarily the best way to learn, right? You go and you sit there for a day or two and you get all this information thrown at you, and then you're supposed to just put it into practice. And, research tells us that's not how we learn. And we probably take about 10% of what we hear and transfer that. That's not a very good return of investment. I like to do my continuing ed courses differently. I usually have what I call like a packet or a worksheet or something where you're following along. I like to have cases in there. You learn some stuff, you do some cases, and then it's like, now let's try it with your, kid that you have in your mind that you're wanting to have a plan so that when you go back, to the clinic, you can start right away with a plan. And I think that's really important. The other thing I think that's important when you teach continuing ed is to teach a process. I am very big on having process involved in everything that I teach because otherwise, what happens is like, particularly like with executive function or vision, these are the topics that I'm really well versed in. You have a laundry list of stuff. It's like, where do I start?
Yes.
Right? And I teach people you need to really think of it from a top-down occupation focus, you have that occupation as the focus. That's where you're starting. And then you're going down from there. So I have people say, okay, what's the occupation? Let's analyze it. Let's think about the context that it takes place in the environment. And then let's say, what can the child do in those steps? And what can he or she not do in those steps? Those are the discrepancies. Those are what we need to address, right? And then if you have a process in place for how to do that, it makes it much simpler. Where do I start? Well, in executive function, you start with impulse control. It's the first thing to develop at 4 years of age, pretty set, which is shocking to most people.
Mhm.
Um, got it. That's why you have circle time at preschool, right? Because you
Yeah.
start with control. Working memory is next. And the third big one, the big three I call them executive function, is cognitive flexibility. Cognitive flexibility is born out of impulse control, also known as inhibition, and working memory. So if you have a problem with cognitive flexibility, you have a problem in inhibition and or working memory. So you have to figure out, is it both? Is it one? If it's both, you start with inhibition. If it's both, or if it's just one, then you start with that one. So having that process, knowing the development, and then having a process, but then always using it in occupation, because we know occupation connects to wellness and health, that's key. So I always have that process in, every course that I teach, whether it's executive function, here's the process. And then I always have evidence. Here's the evidence because therapists don't have time. So
Yeah.
I'm going to bring it to you, and I'm going to bring it to you in a way that here's the table with, I always have like a table. People always say they know my courses because they're like, they look the same.
Mhm.
Here's all the recent evidence that I've already checked to make sure this is probably the best that we can use right now. Like I love a systematic review, to really show you here's what it's saying. And then it's like, okay, I have the process, I have the evidence. Now, what do I do with that? How do I incorporate that? I want people to know these are the steps that I do it. Here's how I'm being true to occupation-based practice. And then here's how I'm going to also assess if what I'm doing is effective. That's important too.
Yeah.
So I
Yeah.
kind of tell them. So my courses, I do a lot for like occupationaltherapy.com. And the nice thing about those is they're 2 hours or 1 hour. So they're a little bit more digestible, which I think is nice. And
Mhm.
you have access to them. Sometimes people think, oh, live courses are better. I'm not sure about that, right? Because if you have access, you can go back and watch things. And I think that's helpful. I also have a podcast with MedBridge called Pediatric Pioneers.
Yes.
Spotify or any place. And if you wanted to turn it in for continuing ed credits, you can. And occupationaltherapy.com is the same way. You can watch them for free. But if you want the credits, that's when you pay for them. I like that approach because now you have access to it. I
Mhm.
nice with a podcast is it's short amount of information, 50 minutes to an hour. So it's much more digestible. It's
Mhm.
conversational, which our brain kind of takes that in a little bit better than a
Yeah.
lecture. And I really focus on the podcast on like top 3 takeaways. What can you do tomorrow that's going to make a difference? Because that
Mhm.
is what we're looking for as therapists. And I think, like you were saying with the burnout, if I have some things that I can take right away tomorrow, I feel like now I've gained something. There was good return on investment,
Mhm.
and I feel empowered, right? To
Yeah.
start something. Hmm.
Yeah. I love that. Do you know, so MedBridge has traditionally been for more of that adult population practitioners. Have they expanded like their exercises on there to kind of fit pediatrics, or is that something they're working on?
They're working on that and they're starting to
Okay.
build it up. And one of the things I am doing with the podcast is I really decided that it would be nice to have course, 3 topics that are similar back to back
Mhm.
to shape that information. So, like, for example, if I was going to look at play, I could do 3 different podcasts on play. And then people really feel like they got kind of this like wide, expansive view on play, the evidence, hearing from pioneers in those arenas. And I'm talking to everyone from researchers to clinicians. So we're getting that kind of nice view and not just researchers. And so I think that's important. So, for example, maybe outdoor play versus, maybe play with within a certain situation. Having all those different situations is kind of nice when that's related. Or like IADLs. Maybe I could do 3 on IADLs. There's a lot of different IADLs out there.
Mhm.
What are some different approaches, or maybe 3 on autism, so that they can think about like, okay, what are some of the under recognized areas for success that we could talk about that maybe aren't always recognized within the autism population. So that's kind of what I'm doing to support. I'm always thinking about how can I better support the people that are listening to this that are going to go tomorrow and work with these kids and change these kids' lives. I want to help
Mhm.
them do that better. So that's
Yeah.
kind of thinking about it with these clusters of 3. But MedBridge is definitely building up some more information. I also have my own business, and I'm going to start putting more courses out there. I want to really focus on a different format, which is here's the course ahead of time. I want you to watch it and listen to it where you can pay attention and you're not in the moment
Mhm.
doing it. You're supported. And then when we meet, we're going to discuss it and we're going to put it together with your case that you brought so that you can directly go in and feel empowered to talk about it, to do it, to explain what's the rationale, why am I doing this, how am I justifying it to the family as well as other professionals so that they know what I'm doing. Again, confident and competent, right? Being that
Mhm.
OT who's adhering to occupation-based practice, that I can explain it, I can do it, I have evidence to support it, and I'm doing it in this confident, competent way. So I have that, piece of it too. And I'm going to start doing some coaching as well for therapists because I get a lot of requests for coaching.
Yeah.
Um, like, okay, let's do it. If you want some coaching, I'm happy to help you.
Okay. Where would people find you for your own course? And what courses are you teaching?
Right. So for my own course, I'm going to be starting, they're going to be short and I'm making them affordable. The first one I'm going to start with is goal attainment scaling because people
Mm.
ask all the time. And I think it's a very effective way to help show the benefits of what you're doing. Sometimes, you just need to know it on a little bit more of a nuanced way. But also, just as important, is goal attainment scaling really helps with building performance patterns, routines, and habits. It helps with that routinization and it helps support the family because now they're tracking and they're seeing success. If you're only relying on someone to say, "Oh yeah, I think he did it," we don't really know,
Right.
or focus on the negative. That's what we do. So there might have been 10 episodes of success, but there was one meltdown. We're going to be like, but if we're tracking it and we're showing the family what you're doing is working, that's priceless. I hear people say the family's not compliant, which is a term I loathe, I'll be honest with
Yeah.
you. I think that create so my PhD is in conflict analysis and resolution. So I hear that I hear a potential for conflict that really doesn't need to be there because we're
Mhm.
all really working towards the same goals. So it's more of a frustration when we think like the family's not doing. I came up with this great home program. I know this will work if they just do it. And then we feel frustrated that they're not doing it, but we have to think about how do we empower them to do it. Goal attainment scaling is a great way because now they're
Mhm.
seeing it. They feel empowered. Again, it goes back to that role confidence for them. And they're feeling like, wow, what I'm learning with the OT is awesome. It's
Mhm.
working. I have data to show it. And then, if they're having a problem at the school, now all of a sudden they're like, oh, I'm working on it at home. And guess what? We just did we had a 80% success rate with whatever they're working on. They get to tell the teacher. And guess what? Now the teacher is feeling positive too. Like there is some hope, right? So that there's so much benefit to doing something where you're tracking progress and goal attainment scale is fantastic for that, especially with kids with like invisible disabilities where you're talking
Mhm.
nuance changes, right? How do I show benefit to what I'm doing? This is how you can do it. So that's going to be my,
So, sorry, go ahead.
that's okay, but that's what I'm putting out there because I get that question all the time about goal attainment scaling.
Yeah. The biggest obstacle we have faced with goal attainment and scaling is it just takes a long time to write the goals. Do you have any tips or tricks or especially and sometimes they're not always conducive to the EMR that you have?
Right. Sometimes the goal attainment scaling, it can be separate. Maybe it's not what you're actually putting as the goals. It might be part of a goal that you have in your EMR,
Mhm.
right? And it might really just be part of the home program. So maybe we think of it as that thing. I definitely have tricks for how to write them and make it easier because you want to make sure that they are equally measured between them. That's really
Mhm.
and it is formulaic. So you could have, I'm a big proponent of a goal bank. I think there's ways that we can do things. If you're somebody who's a meal prepper and you're like, it makes my life easier because I make my meals on Sunday night and I grab them and it makes my life so much easier. A goal bank is very similar. You have goals. And we might step away from that and say, ooh, that doesn't feel client centered or individualized. You can tweak them but you don't have to start at zero. You could start at 75% and say 75% of the goal is kind of written, but now I'm going to think about Joey and I'm going to say, let me just tweak the rest of the 25% of that goal to make sure it fits with him. But
Mhm.
inhibition, there's only, there's a really things that you measure are kind of similar. Then you just put it into context of the occupation, right? Or if
Yeah.
it's memory, there's only so many ways you can write that goal. Or, it's the same thing with meltdowns. If I'm working on trying to get meltdowns, I might not write the goal that they're not going to have meltdowns. That's not a goal that I'm going to write for EMR. But for the home program, what we want to probably recognize is the kid's going to have meltdowns. But is he or she implementing the strategy? We want to get that. Is he or she starting to have less meltdowns? Are they shorter in duration? That's success. If you go from 2 hours to half an hour, that's a big success. We want to measure that. But if we're only saying the meltdown, we haven't seen change.
Right.
Attainment scaling really starts to show you, yes, change is happening. Keep going. What you're
Mhm.
doing is working. So I think a goal bank is a good place to have a start to help you. And that could be true for EMR too. So I think it's just kind of really understanding the purpose of the goal attainment scaling in that moment for what you're designing it for, and understanding, are there some tricks that I can use to kind of make it easier for me, but know that it would be really effective to have it as part of a home program. But it
Mhm.
be something that you're keeping track of too. And some of them do overlap with the goals in the EMR. So it's like figuring that out. Again, there's a process to it, right? And it's kind of learning that process of understanding why I'm doing it, what I'm doing it for, what's the purpose, how am I justifying it, and what do I expect to see. So that's what I want people to feel. If you're very clear about that, there's not a problem.
Mhm.
It's when you're fuzzy, that's when things get tough, and that's when you start to burn out.
Yes. Yes. Any more you want to talk about what you're doing personally?
Okay, so yeah, so I'm in the process of starting this business. A lot of it is because I'm constantly having people reach out to me and ask me. So I just kind of was like, I should be doing this.
Yeah.
I talk a lot about we should monetize our magic.
Mhm.
So I'm gonna do it. Because I really think that when you start to um get out there and support other therapists, only good can come from that.
Mhm.
So focusing on it is the quintessential therapy and consultation is the business. And I really am out there. People want to connect with me on LinkedIn or on Facebook. I tend to put things out there for people to come find me. You can also get me at info@NicoleQuint.com. And that's, people reach out all the time. I'm always putting courses out there. I'm getting my website up. So, I'm pretty much available. People can reach out to me. Um, Also, just whether they're taking my courses or they're taking listening to the podcast. I hear from people all the time. So I have different emails out there because people know that I work at NSU at Nova Southeastern University. They can reach out to me there too. So it's kind of like wherever you find me, I'm always like, find me and just reach out.
Yeah. Okay. I'll put that stuff in the show notes too, so people can have access to it. Yeah.
Kind of find me, nowadays you're kind of everywhere, right? So it's kind of like, people reach out to me, but if you reach out to me on Facebook or LinkedIn, I'm going to find you pretty easily. If you hit me an email, sometimes I tell people that's harder because you might get lost in the different folders and things like that. But I'm out there. I'm always willing to chat with therapists. I'm here to support therapists, really, like you said, overcoming burnout, being the best practitioner they can be, and really leaning into our OT strengths that we have. We bring a lot to the table, and I want people to really be clear, have that clarity on it, own it, and feel good about it. That's really what
Mhm.
I, because
Mhm.
we're special. There's not very many of us. We're like little unicorns running around.
Yeah. One last question for you. How have you tied in your background in conflict resolution into what you do? I mean, I can kind of see that, but if you can speak to that a little bit, and do you um, throw little unicorn glitter into your courses about that?
I do. People think that I went for conflicts between people. I really didn't. Even though that's part of it. My interest was actually conflict in systems and
Mm,
accessing systems, particularly for people with disabilities. But I'm also very interested in internal conflict, which is the conflict we have inside of us. I think that's very important when we think about occupational therapists and occupational therapy assistants and kind of just our own professional challenges that we deal with in this very challenging healthcare arena. So I'm very interested in conflict from that perspective. And I'm also interested in the conflict that does happen within the system between people. And that was what my dissertation was on. Yeah, so I do sprinkle it in courses and I do use conflict language sometimes to talk about things. So I do sprinkle it in there. I think it's informed a lot of my current research. So I'm really focused right now. I have a research partner, Melissa Schaefer. She was also a guest on Pediatric Pioneers. We have a model for school-based OT and focusing on transitions throughout the entire experience because we've looked at some of the conflict that we think happens professionally for OTs when we go into the school system. We that's where we work the most. But when you think about it, we are educated really in the healthcare model, and then we're getting thrown into the education model. It's a totally different ballgame, and
right.
I suffer professionally because of that. And so we're wanting to create this strong framework that OTs that work in school-based therapy can really use to advocate for working with kids throughout the whole experience, getting us the seat at the table in the transition process, or maybe even creating our own table, if you will, to really help students benefit from what we have to bring. And we're also big proponents of OTs as case managers because we think that that is a huge potential role for us, not only in the hospital setting, but also in school based. I'm also very interested in OT in primary care. Right now, I'm working
Mm,
on OT in primary care in the pediatrician's office. Again, that's that conflict of like, why are we not there? It's a professional barrier, I guess maybe might be
yeah.
a challenge, if you will. And really, the research is very clear that we belong there, people benefit from it. But we haven't figured out the reimbursement model. So that's
Yes.
what's the sustainable reimbursement model, not just a grant funded approach. So trying to figure out those challenges within billing to do it.
Mhm.
So that's what we're focused on with that. And then the third thing that I'm very interested in is practice scholarship in occupational therapy. So this is an arena that is used by nursing, pharmacy, psychology, which is, we tend to rely a lot on research, empirical research. And that's really the basis for where we get all of our knowledge that we're supposed to use in the clinic. And it's also typically what we need, what we have for promotion criteria in universities using Boyer's model. And it's all empirical research. And then when you look at the ACOT standards for entry level education, they focus on empirical research. And then we have this capstone that they call the experience. So I work with Penny Moyers and we created a practice scholarship model because we're really focused on solving practice related problems in a rigorous scholarly fashion that can then be integrated into practice. It's transferable immediately, whereas research takes 17, there's a 17-year gap. And you have to think about like, how do I put this into practice? Practice scholarship, you just look at it and say, what do I just need to change a couple things? Okay, I'm putting it in there. And this will address the gaps of like the lack of clinical guidelines. There's 10 categories, whether it's program development, innovation, implementation science, um, advocacy, so changing laws and things like that. Um, as well as, program developments and tried and true quality improvement. Those are perfect for OTs, but we want those to be recognized as sound research approaches. It's just different.
Mhm.
It's its own category in the promotion criteria. We want clinicians to know how to do it and practitioners so they could do clinical ladders or they can start to show like, hey, I do this amazing stuff. I've solved a practice problem. How do then I
Mhm.
put it out there so it's transferable to others?
Mhm.
And that's what my students do in our post-professional DROT program at Nova is they are solving practice problems and putting it out there so people can say, oh, okay, I have the same practice problem. Now I have a solution for it, and
Right.
their circle of influence, which I think is really important. And that's
Yeah.
what we should be doing as OTs. That's where we can really show our amazing skill set that we have.
Mhm.
Those are my focus areas. So I think those are all born out of my clinical experience as well as my academic experience and then shaped by my conflict lens that I bring to the table too.
Amazing.
So
You just have a few things you're working on.
like to keep busy, like all OTs, we all like to keep busy.
Right, right. Yeah. Well, I appreciate this conversation today. It's been a wealth of knowledge and information, and I will put everything in the show notes and so people can come find you.
Sounds good. Thank you so much, Stephanie.